Have you ever woken in the night parched as if you'd run a marathon? Do you find yourself sprinting to the bathroom so often it disrupts your day? Perhaps you've noticed wounds, even small paper cuts, refuse to heal, or your vision blurs when you glance at your phone. These seemingly minor annoyances may, in fact, be early alarm bells of diabetes. As a physician who's guided hundreds of patients through every stage, from the first suspicious fingerstick glucose to long-term complication prevention, I want to take you on a deeper dive, recognizing early warning signs. Polyuria, frequent urination. When blood sugar rises above about 180 mg/dL, your kidneys begin to spill glucose into the urine, dragging water along and forcing you to go again and again. Ask yourself, are you voiding more than 8 times daily, or waking 2 or more times each night to urinate? Polydipsia, excessive thirst. That relentless thirst isn't just a dry mouth. It's your body pleading for fluid to replace what it's losing in urine. If a gallon of water a day still leaves you thirsty, it's time to suspect hyperglycemia. Polyphagia, increased hunger. Even with a balanced meal, your body may be starving at the cellular level when insulin can't usher glucose into your tissues, so you eat more, yet keep losing weight. Unexplained weight loss. Losing 5 to 10% of your body weight without dieting, especially muscle mass, suggests your body is burning fat and protein for fuel because it can't access glucose. Fatigue and brain fog. Glucose is your brain's primary fuel. Without it, you feel sluggish, irritable, and struggle to concentrate on simple tasks. Blurred vision. High glucose levels change the shape of your eye's lens, producing intermittent blurriness until sugars normalize. Delayed wound healing and infections. Elevated blood sugar impairs white blood cell function, making you more susceptible to skin and urinary infections, and any cut or bruise takes an age to mend. Peripheral neuropathy. Tingly, burning, or numb feet and hands often herald the first nerve damage of diabetes. Action point. If several symptoms fit you, arrange a fasting plasma glucose, HbA1c, or oral glucose tolerance test without delay. Early intervention preserves long-term health. Understanding the underlying biology. At its core, diabetes reflects a disruption in the delicate balance between insulin production and insulin action. Type 1 diabetes. An autoimmune attack on pancreatic V cells destroys insulin production. Abrupt onset, often in children or young adults, with classic DKA symptoms, nausea, abdominal pain, rapid breathing, and fruity breath. Requires lifelong insulin replacement via injections or pump. Type 2 diabetes. Begins with insulin resistance. Muscle, fat, and liver cells ignore insulin's signal to absorb glucose. Pancreas initially overproduces insulin, then progressively burns out, making less. Strongly linked to excess visceral fat, sedentary lifestyle, and genetic predisposition. Can often be managed, especially early, by diet, exercise, and oral injectable medications that improve insulin sensitivity or augment insulin secretion. Other forms gestational diabetes develops during pregnancy, increasing both mother's and baby's risk of future type 2 diabetes. Monogenic diabetes, MODY, stems from single gene defects, often misdiagnosed as type 1 or type 2. Secondary diabetes can result from pancreatic disease, medications, e.g. steroids, or hormonal disorders, Cushing's syndrome, acromegaly. Why it matters? Treatment differs by type, so establishing the correct diagnosis guides insulin use, oral agents, or lifestyle focus. The high stakes, complications of uncontrolled diabetes. Chronically elevated glucose causes microvascular and macrovascular damage. Macrovascular coronary artery disease, up to 2 to 4x increased risk of heart attack. Cerebrovascular disease, heightened stroke risk. Peripheral arterial disease, Poor circulation to legs can lead to non-healing ulcers and even amputation. Microvascular diabetic nephropathy, leading cause of end-stage renal disease. Watch for microalbuminuria as the earliest sign. Diabetic retinopathy. Numbers remind us this is the leading cause of new blindness in working-age adults. Yearly dilated eye exams are vital. Diabetic neuropathy. Nearly half of patients develop nerve damage, manifesting as pain, numbness, or autonomic dysfunction, orthostatic hypotension, gastroparesis. Other infection risk. Soft tissue infections, osteomyelitis, and sepsis rates rise when sugars run high. Mental health. Depression and anxiety are twice as common in people with diabetes, creating a vicious cycle of self-care neglect. Prevention. Intensive glucose control, A1C, 7%, plus management of blood pressure, 130/80 mmHg, and lipids, LDL, 70 mg/dL in high-risk individuals, cuts complication rates dramatically. Advanced management strategies for diagnosed patients. If you carry a diabetes diagnosis, consider a multi-pronged, evidence-based approach. A. Nutrition therapy. Carbohydrate counting. Track grams per meal, 15-gram 1 carbohydrate choice, to match your basal bolus insulin or oral agent dosing. Glycemic index load. Prefer low GI foods, steel-cut oats, barley, legumes, to reduce postprandial spikes. Balanced macro ratio. Aim for 45 to 60% calories from carbohydrates, focused on complex sources, 20 to 35% from fats, emphasizing monounsaturated omega-3 fats, and 15 to 20% from lean proteins. Timing. Consistent meal spacing, every 4 to 6 hours, helps stabilize glucose and minimizes extremes. B. Physical activity. Aerobic exercise, at least 150 minutes week of moderate intensity, e.g., brisk walking, cycling, swimming. Resistance training, 2-3 sessions week building. Large muscle strength improves insulin sensitivity. NEAT, non-exercise activity thermogenesis. Increase daily movement. Take stairs, park farther away, stand every 30 minutes. C. Pharmacotherapy. First line, metformin improves insulin sensitivity and modestly promotes weight loss, low hypoglycemia risk. Second line adjuncts, SGLT2 inhibitors, e.g. empagliflozin, reduce glucose reabsorption in the kidney, lower blood pressure, and cut heart failure hospitalization. GLP-1 receptor agonists, e.g. liraglutide, enhance insulin secretion, slow gastric emptying, and support weight loss. DPP-4 inhibitors, thiazolidinediones, sulfonylureas, each have specific profiles. Work with your doctor to choose what suits your goals and tolerability. Insulin therapy, essential in type 1 and often in advanced type 2, available as rapid-acting, meals, basal analogs, once or twice daily, or pre-mixed formulations. D. Monitoring and technology. Self-monitoring, blood glucose, SMBG, at least before meals and at bedtime if on insulin. Frequency adjusts based on stability and treatment changes. Continuous glucose monitoring, CGM, provides real-time glucose trends and hyperglycemia alerts, shown to improve control and quality of life. Automated insulin delivery, artificial pancreas, CGM-guided pumps that adjust basal insulin almost automatically, ideal for type 1 and some type 2 patients. E. Preventive screenings, A1C every 3-6 months, depending on stability. Annual, eye exam with dilation, foot exam for monofilament sensation, urine microalbumin, lipid panel, liver function if on statins. F. Psychosocial support. Enroll in diabetes self-management education programs, DSME. Seek mental health support. Integrated care improves adherence and outcomes. Lifestyle avoidances to minimize risk. Whether already diagnosed or at risk, certain habits accelerate harm. Sugary beverages. Even 1 can of soda daily raises diabetes risk by 20%. Late-night eating disrupts circadian regulation of insulin. Prolonged sitting triggers lipoprotein lipase suppression, worsening lipid and glucose metabolism. Smoking increases insulin resistance and vascular injury. Excess alcohol. Binge patterns cause unpredictable hypoglycemia or spikes. Evidence-based prevention for those without diabetes. Millions have prediabetes, A1C 5.7 to 6.4%. You can break the progression. Weight loss. Each 1 kilo lost reduces risk by 16%. Structured lifestyle programs, National Diabetes Prevention Program, DPP, achieves 58% risk reduction with 150 min week activity plus 7% weight loss goal. Mediterranean or DASH diet, high in fruits, vegetables, whole grains, nuts, linked to 30–40% lower diabetes incidence. Regular risk screening, fasting glucose, A1C, and oral glucose tolerance tests per USPSTF guidelines, especially if BMI chasard 25 km2 or family history positive. Stress reduction and sleep hygiene, chronic insomnia or shift work doubles diabetes risk over a decade. Aim for consistent 7 to 9 hours nightly. Key questions to ask your healthcare team. Given my A1C and glucose patterns, where should I set my individualized targets? Which medication class aligns best with my heart and kidney risk profile? How can I integrate CGM or insulin pump therapy into my daily routine? What is my plan for hypoglycemia prevention and treatment? Which community or digital resources can help me sustain lifestyle changes? Closing thoughts. Diabetes is not a single event, but a lifelong journey. The sooner you recognize symptoms, understand the biology underpinning them, and partner with your healthcare team on a tailored plan of nutrition, exercise, monitoring, and medication, the more you safeguard your future, free from blindness, dialysis, or heart attack. Remember, every healthy meal, every step you take, every glucose check, is an investment in decades more of vibrant living. By treating diabetes with the seriousness of a prescription and the compassion of a caring guide, you can master this condition and prevent it in those yet untouched.